Hello and welcome to today's event, Lessons Learned from Medicaid Section 1115, Substance Use Disorder Demonstrations, Provider Capacity and Initiation and Engagement in Treatment. My name is Chris Talbot and I'll be the technical host for today's event. Before we begin, I want to cover a few housekeeping reminders. All participants have been muted upon entry for best sound quality possible today. You may enter any questions or comments that resonate with you throughout today's presentation via the Q&A panel. To access the Q&A, please select Slido located in the lower right-hand corner of your screen. Once you're there, you'll be able to submit your questions in the Q&A. If you should experience any technical issues with the webinar platform, please use that same Q&A tool to contact me directly, and I'll work to resolve any issues you may encounter. If you would like to enable closed captioning, please click the closed caption icon in the lower left corner of your screen, or press Ctrl-Shift-A. Lastly, the recording and transcript will be posted to Medicaid.gov. It may take a little time to get it there, but we will make sure it gets posted shortly. Thank you. Now, I'm pleased to introduce J.C. Cooper, the Director of State Demonstrations Group at CMS. J.C., the floor is yours.
Thank you so much, and welcome to today's webinar. We will be talking today about lessons learned from Medicaid Section 1115 Substance Use Disorder Demonstrations. CMS is thrilled to offer the opportunity today to discuss federal evaluation efforts and to hear from several states regarding their promising strategies. Thank you for joining, especially our state panelists from Louisiana, Minnesota, New Jersey, Vermont, and Washington. We appreciate all of the hard work that you do and look forward to learning and hearing from you today. There are now 1115 SUD demonstrations in 36 states and the District of Columbia. Most of the demonstrations started several years ago and with approval dates from over 8 years ago and as recently as 2 months ago. So we're really excited about the longstanding policy as well as the growth that we have had over time across the U.S. CMS is committed to learning from the demonstrations and sharing that information broadly, including with states. We hope that the lessons both from CMS's evaluation efforts and from our state panelists will help you improve care for individuals with substance use disorders within your own states. During this webinar, we're also focusing on two very critical aspects of the substance use disorder demonstrations. This includes findings from strategies related to provider capacity and initiation and engagement in treatment. Critical areas to have success in these demonstrations. Provider capacity is a key aspect of the delivery system. It's very challenging to provide services to beneficiaries seeking care if the provider workforce is limited, if providers are overburdened, if inefficiencies exist in the delivery system, to name a few important provider capacity factors. And we'll hear from a few states about ways that they have addressed these issues and concerns. And hopefully you'll be able to use some of the ideas that they share with you today. Additionally, receiving early and consistent treatment has been demonstrated to improve health outcomes for individuals receiving services. While treatment programs for individuals with substance use disorder are numerous and show success, we know challenges exist with individuals with substance use disorder to the appropriate level of care, and including specifically the initial engagement in treatment. We'll also hear from a few states about strategies they have used to enhance initiation and engagement of treatment, which is really critical to have improved outcomes at the end of the demonstration and forward. So we hope that today's webinar is informative and interactive, and we appreciate your participation and your partnership with CMS. Today with me, Kirsten Baronio, our Senior Policy Advisor for Behavioral Health, will help facilitate the webinar, and we greatly appreciate her doing that. So to get us started, I'd like to introduce the very talented and insightful Dr. Shu-Ching Su from CMS, who will be presenting the overview of the findings from our federal evaluation efforts, After her presentation, we'll transition to our panel discussions with the states. I hope you enjoy our webinar today. Thank you so much.
Hello, and thank you. Next slide. All right, so we'll start off today, previous slide. So we'll start off today with providing some brief information to help provide some context on the Medicaid Section 1115 Substance Use Disorder or SUD demonstrations. Next slide, please. Next slide. Oh. The Centers for Medicare and Medicaid Services support states implementing Medicaid Section 1115 SUD demonstrations to help apply best practices and improve access to high quality, clinically appropriate treatment for beneficiaries with SUD, to encourage activities aimed at preventing opioid addiction and overdose deaths, and to improve the continuum of care for SUD treatment services, which include providing Medicaid coverage for residential treatment. The State Medicaid Director letter about the SUD demonstrations outlines 6 goals and 6 milestones as displayed on this slide. The goals and milestones cover a wide range of SUD-related objectives, for example, related to the prevention of opioid abuse, coverage of and sufficient provider capacity for critical levels of care, and increasing engagement in treatment. The State Medicaid Director letter also outlines specifications of state implementation activities related to each milestone and the proposed timeframes for meeting them. States are required to conduct systematic monitoring and evaluation of SUD demonstrations to monitor progress towards goals and milestones, and that information feeds into federal evaluation efforts, which we will discuss later. Next slide, please. So the map here shows which states have approved or pending 1115 SUD demonstrations. As of January 9th of 2024, 37 states had approved demonstrations. Those states are noted in green on this map, and 2 states had pending applications, and those states are noted here in navy blue. While most of the SUD demonstrations were approved by CMS in 2018 or 2019, the earliest one was actually approved in 2015, and with the most recent one being approved in 2024. Therefore, states are generally in varying phases of their implementation. I note that there are also 21 states noted here with an underline with age-adjusted overdose deaths above the national average in the year 2021. And 17 of these states have an approved SUD demonstration. Next slide, please. So next we'll discuss the federal evaluation efforts for SUD demonstrations and some of the key findings from them. CMS works with 2 partners to support monitoring and evaluation of the demonstrations. Next slide, please. So CMS conducts regular cross-state analysis of state Section 1115 SUD demonstration monitoring data. And the objectives of this analysis are to understand the extent to which demonstrations are meeting demonstration milestones, goals, and requirements, and also to highlight commonalities across states. The analysis uses data from the standardized SUD metrics and narrative information from state-submitted quarterly monitoring reports. For narrative data, themes are analyzed and relevant information is included in the analyses of the goals and milestones. And the report also helps summarize data by theme and by state in its appendices. The analysis includes regressions for monthly metrics to analyze the association of the demonstrations with observed metrics trends, and also provides results from z-tests for annual metrics to assess whether differences that were observed between years for annual metrics were likely attributable to normal variation. A report that analyzes monitoring data submitted through June 1st of 2022 is publicly available on Medicaid.gov, and the analyses are ongoing, and some of the upcoming slides that we present today provide some more recent analyses than those that are currently available on Medicaid.gov. Next slide, please. CMS is also conducting a meta-evaluation of the Section 1115 SUD demonstrations, and the objectives of this work are to study the effectiveness of SUD demonstrations across states, to identify factors associated with variations and impacts across states, and to help inform national policymaking and support the diffusion of successful demonstration experiments. This analysis uses multiple data sources, including state implementation, monitoring, and evaluation reports, interviews with state officials about demonstration features, context, and implementation experiences, as well as Medicaid claims data and other data sources. 4 reports that are focused on pre-demonstration characteristics of states and state experiences with implementation are currently available on Medicaid.gov. Next slide, please. So in this webinar, we'll focus on findings that are related to provider capacity and initiation and engagement in treatment. For findings and other topics, you can refer to the public reports that were mentioned on the previous slides. And provider capacity here corresponds to milestone number 4 for the SUD demonstrations, under which states are required to ensure sufficient provider capacity at critical levels of care, including medication-assisted treatment, MAT. As discussed in the state Medicaid director letter, states are also expected to complete an assessment of the availability of providers that are enrolled in Medicaid and are accepting new patients at each critical level of care. They also report annual metrics with CMS in relation to provider availability. Next slide, please. So one of the metrics that states report is related to milestone number 4 is the annual number of Medicaid enrolled SUD providers, so metric number 13, and higher rates for this metric is better. In order to allow comparison of this metric across demonstration years, the rate here is normalized, and the cross-state analysis that analyzed data submitted by June 2022, and it looks at rates of SUD providers per 10,000 adult Medicaid beneficiaries. And this metric is calculated by taking the number of SUD providers divided by the number of adult Medicaid beneficiaries, and then multiplied by 10,000. So amongst 19 states with available data, this rate significantly increased in 3 states and significantly decreased in 9 states. And notably, in some states that had a significant decrease in the rate of SUD providers per 10,000 adult Medicaid beneficiaries, the total number of providers increased. So the rate here declined in these states because the increases in the Medicaid population was greater than the increases in providers, likely due to states maintaining continuous Medicaid enrollment of beneficiaries during the public health emergency. However, starting with analyses in 2023, we instead used a denominator of 1,000 Medicaid beneficiaries diagnosed with SUD based on annual metric number 4. That way, the rate of provider availability would not be impacted by fluctuations in enrollment due to continuous enrollment requirements and unwinding. Although this rate, SUD providers per 1,000 Medicaid beneficiaries with a SUD diagnosis, is more closely linked to treatment need, an important limitation is that SUD diagnosis rates may be influenced by provider availability. So in our analysis of data that's available as of June 2023 among 17 states, the rate of SUD providers per 1,000 Medicaid beneficiaries with a SUD diagnosis significantly increased in 8 states and significantly decreased in 6 states. Notably, using these newer data and the updated methods that we've just described, more states had a significant increase and fewer states had a significant decrease than in the 2022 analysis. Some states also provided narrative information related to these trends in their monitoring reports. States cited a range of workforce challenges that were barriers to sufficient provider capacity, and they also implemented actions to address these challenges, such as adding new provider types, increasing reimbursement rates, using grant funding to support workforce development and retention, which Washington will discuss later in its panel, and changing requirements for MAT providers. Next slide, please. So as I discuss the challenges and strategies that states have implemented regarding provider capacity, there will be an audience poll in the Slido panel in WebEx about the strategies that your states have implemented. So please feel free to answer that poll question over the next couple of minutes. So during interviews with 31 states that were conducted in late 2020 into 2021, states with SUD demonstrations identified several challenges that were related to provider availability. Prior to the demonstrations, only a few states covered a broad array of services across the SUD continuum. And state officials also noted that SUD providers lacked the necessary administrative infrastructure, computer systems, or staffing in place to meet Medicaid's participation and billing requirements. About half of the states attributed challenges to expanding access to SUD services to ongoing shortages of SUD providers. State officials also reported gaps in the number of and geographic distribution of OBOTs and OTPs as a challenge to increasing access to MAT. Shortages were particularly prevalent in states with large rural or frontier populations. About 2/3 of state officials reported experiencing resistance to MAT among the SUD provider community, which impacted their ability to expand access to therapeutic medications to treat SUD. Officials also reported that some residential providers lacked the appropriate knowledge to navigate the logistics of daily dispensing, medication storage and management, and monitoring of beneficiaries receiving MAT. Finally, a few state officials reported challenges with developing reimbursement rates to account for the additional expectations of residential providers to provide access to MAT. State respondents also identified several strategies for addressing these challenges. State officials educated and trained providers on Medicaid program design, benefits, and billing practices during the early months of the demonstrations. They also solicited feedback from providers on various reimbursement models prior to implementing new policies to help facilitate provider acceptance and buy-in. Educating providers early about payment options helped to mitigate confusion, enhance trust, and also allowed for more informed commentary on rate development rather than reactionary feedback. States also noted that telehealth helped expand access to behavioral health care in many states, particularly in rural areas, and many state officials considered telehealth to be a long-term solution for addressing the mental health and SUD workforce shortages. State officials also conducted outreach to community-based providers, and a few states also focused on access to non-emergency medical transportation to help residential providers comply with MAT requirements. Next slide, please. So next we'll discuss some of the key findings related to initiation and engagement in treatment. The findings included here span 2 milestones that relate to this topic. Specifically, some findings focus on the use of patient placement criteria and utilization management, which are related to milestone number 2, and other findings focus on care coordination and transitions, which are related to milestone number 6. The state Medicaid director letter outlines specifications for these milestones, for example, implementing requirements to use patient placement assessment tools that reflect evidence-based clinical treatment guidelines. Next slide, please. So this slide here summarizes the number of states that made changes to their patient placement criteria or utilization management as a part of their SUD demonstrations. These results here are based on 29 states with a SUD demonstration as of July 2021. So 17 states added or updated their patient placement criteria. 7 states adopted nationally recognized evidence-based criteria for the first time. 24 states added or updated their utilization management approaches. 8 states implemented SUD-specific utilization management approaches for the first time. And then there were 4 states that actually had both components in place prior to their demonstration, and so made no changes to them. Next slide, please. So during interviews, state officials identified several challenges for implementing strategies towards milestone number 2. Prior to the demonstration, providers in some states had considerable flexibility and autonomy in making treatment recommendations for beneficiaries. State Medicaid regulations do not routinely require that providers apply patient placement criteria. MCOs do not necessarily have SUD-specific utilization review processes in place. Therefore, in some states, providers lack familiarity with evidence-based SUD-specific patient placement criteria. Some state officials also described evidence-based criteria, such as ASAM patient placement criteria, as being vague and open to interpretation, making it challenging for providers and MCOs to apply the guidelines consistently. And prior to the demonstrations, MCOs did not necessarily have SUD-specific utilization review processes in place, which meant that the organizations needed to develop processes and infrastructure. And to address these challenges, states have applied the same education and training strategies as those adopted to address providers' lack of familiarity with Medicaid, which were described earlier on. Some state officials pulled together stakeholder work groups And one state official highlighted the importance of having clinicians from the MCOs attend its work group meetings to help explain the service authorization process. Next slide, please. So care coordination aims to ensure that individuals transitioning from inpatient and residential services are linked to less intensive SUD treatment services and other recovery support services in the community. This slide here summarizes the number of states that made changes to their care coordination policies as part of the demonstration. These results, again, are based on 29 states with demonstrations as of July 2021. 19 states added or updated their care coordination policies. 8 states added or updated care coordination requirements for providers. 5 states added or updated peer support and SUD case management services as a care coordination policy. 9 states added or updated care coordination requirements and managed care contracts for individuals with SUD. And 10 states reported that they did not need to make changes to meet the requirements of the milestones. Next slide, please. So for milestone number 6, states report on a few metrics, including one about engagement of individuals in treatment within 34 days after they have an initiation treatment visit for a new OUD diagnosis. Higher rates are better for this metric. In the cross-state analysis that analyzed changes from 2019 to 2020 among the 14 states reporting data, treatment engagement for those with OUD significantly increased in 5 states and significantly decreased in 2. A more recent analysis of changes from 2020 to 2021 across 18 states, treatment engagement for those with OUD significantly increased in 5 states and significantly decreased in 7 states. Notably, the metric decreased significantly in a greater number of states in this more recent analysis. Although states did not provide narrative information to help explain increases or decreases in treatment engagement, states did provide narrative information on efforts to increase engagement. 4 out of 5 states that saw significant increases reported activities related to this milestone. For example, Minnesota established a direct access initiative, which I will be speaking about in the upcoming panel, allows beneficiaries to choose their preferred provider in order to receive an assessment and connect with the appropriate level of care. Some states that experienced a decrease in this metric also reported efforts to improve care coordination. Next slide, please. So the cross-state analysis is ongoing, and it continues to include more monitoring data as new reports become available. Additional reports from the federal meta-analysis are forthcoming on Medicaid.gov. These reports will summarize findings from interviews with managed care and provider organizations in a subset of states about their experiences with SUD demonstration implementation. We also anticipate conducting follow-up interviews with state Medicaid directors focused on later demonstration implementation experiences and sustainability of efforts. Additional reports that become publicly available will be posted to Medicaid.gov. And now I will turn it over to Dr. Danielle Daly, who will lead us for our Q&A session.
Great, thank you so much. It's so wonderful to hear about all of the monitoring and evaluation efforts. So if folks have any questions on CMS's federal monitoring and evaluation efforts, feel free to utilize the Q&A box in Slido. We're happy to take questions. I will note we have time for only a few questions because we really want to make sure that we get to our state panels and can hear from our state panels. So feel free to type anything in the chat. In the meantime, I think let's share the results of our poll question and we will take a look at those together. Okay, so you should be seeing on your screen now the results for the poll question. And the poll question was, what strategies has your state used to address challenges you've experienced related to provider availability? So it looks like we have some great responses. The top 2 responses are at the top and are highlighted in blue. Those are educating and or training oh, look at this. We are shifting in the middle. Okay, so it looks like 71% are expanding telehealth to address limited access. That is really, really wonderful. And I think that definitely feeds in nicely to some of what our panels will be discussing as well. So perfect. Okay. So thus far, we don't have any questions in the Q&A. Feel free, though, as we're going through, if you have any, CMS can always follow up after the webinar. But I will turn it over to Kirsten Baronio to get us started and kick off our state panels. Kirsten?
Great, thanks, Danielle. Welcome, everyone, and thanks, Dr. Zhu, for that great presentation on the findings at the federal level, what we're seeing in the data that states are reporting that are participating in this demonstration opportunity. We're really excited to have some representatives of states, some of the states who've had some good success on some of these topics, join us today to talk about their strategies in addressing, first, provider capacity. We know that there are widespread issues with availability of substance use disorder treatment providers. So, you know, that's a really key issue. We're well aware of that's a challenge. And also know that it's often helpful for states to hear from representatives of other states and how they're addressing some of these challenges at the state level. So for this first panel, we're welcoming representatives of two states, Vermont and Washington, to discuss their strategies because they have had some successes in increasing availability of SUD treatment providers. And while we're having this panel discussion, we're also going to have another poll that's going to be open in the Slido panel on WebEx, asking about levels of care most affected by provider availability. So feel free to answer those questions at any time during the panel. And then we'll also be answering some audience questions later on. So feel free to submit those in the Q&A section of Slido. If you open up Slido, there's two sections, Q&A and poll. So I'm very pleased to welcome to the webinar today, Tony Folland of Vermont and Tisha Kirschbaum and Tony Walton of Washington. We can go to the next slide. Yeah, this just outlines some of the topics that we've asked our panelists to talk about today, namely a strategy that they've used to increase provider capacity, any outcomes they've seen from this strategy and how they've adjusted their strategy over time, and then what advice they might have for other states embarking on similar work, what are their lessons learned. So with that, I think I will turn it over to Tony Folland from Vermont. Tony?
Hi, thank you, and nice to meet everybody. I hope you're all having a wonderful day. Again, as folks mentioned, my name is Tony Folland. I work for the state of Vermont. I'm the Clinical Services Manager in the Division of Substance Use, which is housed in the Vermont Department of Health, and I'm also the State Opioid Treatment Authority for the state of Vermont. So real quick information, Vermont was early adopter of the 1115 demonstrations. In fact, we had our first global commitment to Medicaid waiver back in 2005. And then we added a SUD amendment, which was approved in July of 18. I'm not going to read through a lot of this. Folks can see the information here. The one thing I want to highlight is that complementary to this, we really leveraged Section 2703 of the Affordable Care Act, which allowed for health home funding for our services, which allowed for a 90-10 Medicaid split match for 8 quarters, which really allowed us to enhance our services while not having to shift a significant amount of funds away from services that were being offered, and to support our expansion of services and our expansion of our provider network. What we really did we treated opioid use disorder as a chronic medical condition. And as such, we were able to leverage funding for one FTE nurse and one FTE licensed behavioral health clinician for every 100 Medicaid beneficiaries we treated with opioid use disorder within office-based opioid treatment, or what the state of Vermont we call spokes. And then while we embedded the staffing into the medical practices in our opioid treatment programs, or what we call hubs in the state of Vermont, what we did was we were still able to leverage 30% of the cost as a new service that looked at really the providing and provision of health home services to bring the OTPs into the general healthcare world by being able to provide coordinated care across the healthcare network for individuals. Next slide. So in addition to the staffing, what we also wanted to do was really develop a bi-directional relationship between our specialty substance programs and the knowledge that they had back to our generalist healthcare partners, who in a rural state like Vermont are our overwhelming workforce of prescribers. And they were willing to prescribe, able to prescribe, they had existing knowledge with patients, but there were some individuals for whom the complexity of their needs needed more consultation. And so if you think of it, we really wanted to replicate the rest of the general healthcare world, where you have a large number of generalist practitioners treating folks with referral and knowledge infusion from specialty providers up through those individuals who needed daily monitoring of medication, who only received their medications upon like a contingency management framework where they had proven and done well and earned the fact that they were stable enough to be able to have existing medications. And then a graduation process where for folks who have done well in those levels of care, they're able to transition into our spoke or our office-based programs. And if somebody decompensates within our office-based programs, that rather than losing care, which happens in most cases, they were able to be referred back to a higher intensity level of service and to continue having their medications managed. Next slide. So I think before I go into this one, I want to talk 3 different metrics that we looked at as part of this. And they all relate to expansion of workforce and expansion of care. The first thing we did was when we started this process back in 2013, our baseline of prescribers within the state of Vermont who prescribed buprenorphine, or at the time had what they called their Data 2000 waiver, was a little shy of 200 people, which still per capita was the highest in the country at the time, but we knew was an insufficient network. Fast forward with these enhancements and all of the pieces that we did within the state of Vermont, when the Data 2000 waiver came to an end at the end of 22, we now had 800, just shy of 800, 784 prescribers who were waivered within the state of Vermont. So we knew we had a workforce available. The second question was our workforce actively treating people? And so we looked at the amount of medication coming into the state of Vermont, looking at ARCOS data, or the DEA tracking data of narcotics coming into a state. And we did a 6-month poll in the first half year of June 2021. And what we found was what we hoped we found. Vermont was #1 in the nation per capita in the provision of buprenorphine being shipped into the state. And it was #3 in the country per capita for the use for methadone being brought into the state of Vermont. So we also were able to say, we know we're actively treating people. The third thing we wanted to look at was, did we have geographic equity such that there was provisions of treatment happening across the state and not just in our one urban-ish area? Vermont, depending on its metric, is either the first or second most rural state in the country. And we wanted to make sure that we had access across the state. We knew we had prescribers in every county in the state of Vermont, including one county that doesn't even have a commercial pharmacy. But we did that poll, and what we looked at was, according to the National Survey of Drug Use and Health, something in the rough area of 1.5% of individuals have opioid use disorder past or present. And we wanted to look at not only aggregately as a state, but also by county, which areas were at minimum hitting that threshold. And what we found was, despite a 1.5% geographic expectation based on NISDA, we actually treat about 2.7% of the Vermont population age 18 to 64. And that we had geographic equity that covered every community with a low range of around 1.8 to 1.9% in one county of that group that were being treated, up to over 4% in some other counties. So really wanted to make sure that everybody was being touched. What we still saw was that we still had folks who were not in care, and we still had folks that were unfortunately passing away from overdoses. So our next thought was, how do we reach those folks that we're not reaching who are at highest risk? And so rapid access to MAT, or rapid access to MOUD, what we called RAM, was really the goal of looking at how do we quickly initiate medication, kind of in a medication first model that we wanted to implement statewide. Oh, and I am seeing that I am out of time. Basically, it brought in the emergency departments, it brought in transitions of care, and allowed us to touch those folks who we had not known or had not seen, who were at the highest risk of overdose by being in acute care settings in crisis. Next slide, and I will just run through these, folks can read them. Goals, we were able to implement statewide, good follow through. We used plenty of medication, and we're able to add services for folks who use alcohol in the same manner. Last slide. So challenges, I think the biggest challenges for us were, there is no data waiver anymore. Do we actually increase access to care? And in the absence of that required training, are there any impacts on quality? While we had a great physician and prescriber uptake of the workforce, nurses and clinicians, particularly in COVID and post-COVID, are really hard to come by. To some extent, we're almost robbing Peter to pay Paul. And then telemedicine is a great implementation and allows for a lot of access to care. At the same time, it has limitations on its ability to medically assess folks and to really coordinate care if individuals are not supplanted in the state of Vermont. And I think the big takeaway in the last one is access is crucial, but don't forget about quality, and that you need to have ongoing technical assistance and training to your field as you grow your workforce and continue to enhance their skills. My apologies for this being so quick and for running over.
Thanks, Tony. I think we'll hear from Washington next.
Good afternoon. I'm Tisha Kirschbaum. I'm with the state of Washington. I'm the Deputy Director of our Division of Behavioral Health and Recovery. And I just wanted to start off by saying just how honored we are to be here today to share some information about some of the strategies we've put in place to help support our workforce. You know, I can't say enough about what Tony just shared about robbing Peter to pay Paul. We really wanted to take a look to say, like, how do we increase the amount of people who are aware of going into behavioral health as a career? Tony, do you want to come on and introduce yourself quick?
Yeah, good morning, afternoon, depending on where you are. My name is Tony Walton. I'm a section manager within the Division of Behavioral Health and Recovery, which is one of several divisions in Washington State Healthcare Authority. And I oversee adult substance use and treatment with the primary focus on expanding access to low barrier programs that provide medication. So it's awesome following Vermont because we actually modeled some of our state opioid response work on the hub and spoke model that they kind of developed. And so really relevant, and that was a great presentation. But here today to talk about workforce and what we've done to try to expand the availability of individuals that are interested in a career in behavioral health.
Next slide, please. So strengthening and stabilizing the behavioral health workforce is absolutely a priority for us. And over the past few years, we have received generous support through federal and state investments. These investments have been vital for us to both increase our services, especially for individuals in rural and underserved areas. And also, we've used some of those investments were directed specifically for investments in our workforce. When we think about workforce development, it is extremely important to acknowledge, one, that workforce is a very complex subject, and this work requires extensive cross-system partnerships. Some of the partnerships that we engaged in very systematically were with other sibling governmental agencies, professional associations, universities, boards, commissions, committees, funders, always very important, and of course, providers and also individuals with lived experience. I do think that part of the key to our success with some of the workforce development strategies we were able to put in place was our collaboration with our state workforce board. So I think just something to think about, that as you move forward, as you think about moving forward with workforce development plans, if you're not already having a strong relationship with your state workforce board, that has definitely been a beneficial partnership for us. So there's three main strategies that I'd like to highlight. The first was just increasing financial resources. There's two big strategies that we have found to be very successful. One was just increasing our Medicaid rates. So we've increased the Medicaid rates by 24% over the past 4 years, with some additional targeted increases for more intensive services. And also, we took a significant amount of funds, about $130 million, in provider relief funds to help stabilize the workforce after the public health emergency. We did this through directed payments, and providers needed to use these funds for recruitment and retention incentives. So for example, like wages or bonuses, relocation expenses, childcare. We heard very loud and clear from providers that they needed this type of a direct payment to help them stabilize their and retain their existing workforce. Another strategy that we have heard and found to be very successful for maintaining and strengthening and stabilizing our workforce was telebehavioral health. So part of what we did is we extended some of the COVID era flexibility. We found that this really supported our remote clinical work and staffing models, which include remote workers, which allow us to reach more rural areas. And also we found that the ability for more flexibility with telebehavioral health, we heard from the individuals who were receiving the services themselves that this assisted them with removing some of the barriers to accessing treatment. We've also continued to significantly invest in peer services, and really focusing on building out peer services in Washington State. So since 2005, Washington State has had peer services as part of our Medicaid state plan on the mental health side of things, but we amended our Medicaid state plan to include SUD peer services under the substance use disorder Medicaid benefits starting in 2019. This really opened up a whole new provider type into this type of work. We have also developed a certified peer counseling training and credentialing program, along with continuing education courses. This professional development, it's not just for people with lived experience who want to become certified peer counselors. It also is, we have a targeted training course for agencies and providers who want to add peer services to their book of business. So for example, in 2023, We coordinated over 100 trainings for certified peer counselors and trained almost 2,000 individuals. Next slide, please.
And something that was identified, and I'll kind of focus in on one of those initiatives, which was our statewide careers marketing campaign. Our workforce assessment identified, to no surprise, that one of the biggest problems we had with the workforce is that we didn't have a supply of interested individuals needed to meet the growing demands. There was a general lack of awareness about behavioral health jobs compared to other jobs like doctors, nurses, teachers, police, and fire personnel, other service level positions in Washington state and other states. And so the careers marketing campaign focused on increasing awareness and interest through a phased approach. Phase one began in 2021 and focused on developing a website, startyourpath.org, and focusing on 4 areas of clinical engagement: licensed mental health counselors, substance use disorder professionals, and peers for both mental health and substance use disorder, as well as prevention specialists work in there as well. In phase 2 and 3, we added custom ads, taped testimonials, and day in the life videos featuring Washington providers, all messaging in English and Spanish. Those ads kind of focused on the 4 elements that you see in the slide around passion, variety, growth, and a connection to community. The ads are running through social media platforms like Reddit, TikTok, LinkedIn, Facebook, and Instagram. Later on, I'll talk about some of the outcomes, some of the data that we've seen through the instances of ads being viewed and a number of times individuals are visiting the website. But we really just wanted to try to engage audiences through passion, opportunity, and connecting people to what they love about this work. So there was a strong focus on incorporating individuals with lived and living experience. So clinicians that are currently doing this work in Washington state and have been doing it and love the fact that they're involved in something where they can connect with another individual on such a critical level in such an important part in their life.
So as Tony mentioned, we have this wonderful workforce development campaign, which is called startyourpath.org. I'm hoping that that link is able to get shared with everyone so you can go play around in it. But one of the things that we found has been very successful as part of our marketing campaign is that we developed stakeholder toolkits to support providers. And to both support providers, but also to explain like educational requirements for going into this field and just basically increase the awareness as behavioral health is an exciting and rewarding career field. So as you go into the site, startyourpath.org, you're going to see that there's 2 different types of toolkits. One toolkit is simply basic information about kind of this workforce campaign. And the other is more customizable. So this was really meant for providers as they would be attempting to hire staff to be able to use it to recruit and market working at their organizations. So really it's intended for smaller agencies to be able to help them with their recruitment efforts. Next slide, please.
And just real quick, I understand we're at the end of our time, but I wanted to show some examples of our digital banner ads and social posts. We also produce a variety of 15, 30, and 90-second video testimonials. Again, testimonials from individuals actually doing this work within Washington state and have a strong connection to the community and the individuals that they serve. Real quick, I just want to talk about some of the outcomes that we have achieved so far. So from 21 to 23, September to October, so 2-year span, we've had over 144 million impressions. which basically indicates the number of instances content was displayed through social media. Again, that's 144 million. 27 million views of the entire video ad without skipping. And so it's amazing that we're able to get these sort of metrics and be able to track this to that level of detail. But that's 27 million times somebody has watched the entire video ad without actually skipping or shutting down their app or their phone or their computer. And then finally, 271,000 website landings. So individuals visiting the website. And so that kind of helps us understand that those ads and the social media platform content is directing individuals to the startyourpath.org. I want to finish with letting you know that in 2023, Washington State also passed a bill that's requiring the state licensing agency to collect demographic data on all healthcare providers. So that we can also have a better sense and understanding of the racial, demographic, gender information associated with individuals wanting to get into the behavioral health field. And so starting January of 2025, we'll be able to have an even better sense of who's doing this work in the state of Washington and how we can kind of gear this campaign and other efforts to ensure that we have an equitable distribution of clinicians in the state. And then I think the final slide is a video, but we'll get that link over to everyone.
Thank you so much for this opportunity to share a little bit. And please do go check out startyourpath.org. Thank you. Back to you, Kristen.
Thanks so much. Really great strategies and suggestions from everyone. Just so much to share. We apologize for moving folks along quickly. We do have another panel coming up, but I did want to open it up for Q&A from the audience. If anyone has questions, type them into the Slido. You can also raise your hand if you're more comfortable with that. But while we're waiting for questions, I think we wanted to see the results of the second poll. Okay, so we had asked which levels of care are most impeded by limited provider availability in your state. And it looks like residential treatment, interesting, is the most often cited as being impeded by provider availability. That's interesting. And then inpatient, group home, etc. Okay, last call. Any questions? Check. Here we go. Got a question to the Washington State panel. Thank you for your presentation. I'm a licensed social worker in Indiana who has worked for a community mental health center. What are some strategies that states could use to address the issue of low wages?
Great question. I think that's part of what we are attempting to do with some of the strategies I talked about at the beginning. So with Medicaid rate increases, and then also the directed payments to providers to maintain their workforce. What we have heard back from providers is that the overwhelming amount, many of them use those directed payments to increase the wages for their staff. Tony, anything to add?
No, that was kind of, I know we've also used our substance use prevention, treatment, and recovery support services block grant to help kind of mitigate that and support clinical retention bonuses to try to ensure that once we have clinicians in place within the behavioral health agency, that we acknowledge the work that they're doing and try to provide bonuses and retention through some of our block grant funding and other funding sources.
Thank you. That was actually one of the questions I had, was kind of how you're incorporating other funding streams into some of these activities. I don't know if you have other thoughts on that, or Tony Folland. If it was very interesting to see how you're kind of incorporating the health home benefit into your work, really kind of bringing together all these opportunities to
if I may,
also,
real quick.
go ahead.
I'm sorry, I was just going to say, we've also just thinking about kind of weaving and braiding funding sources. We've also used opioid abatement settlement funds to try to contract with the State Board for Community and Technical Colleges to provide flexible scholarships, focusing on underserved populations and getting individuals that have historically not had access to the behavioral health education. And so that's, you know, I think it takes a lot. It takes a lot from different funding sources, as well as, you know, really addressing this issue from a number of different directions. Yeah.
Yeah. I just quickly also wanted to highlight the importance of peers. I really appreciated, you know, the work you're doing to support that career path. Just wondering if as you're kind of bringing people into the peer role, if there's work also to then move them into the, you know, higher credentialed, maybe higher paying roles as well. If you have any thoughts on that, I've often been curious about how folks are addressing that issue to really create a career path for those folks.
Absolutely. That's actually something that we talk about quite a bit. We want people to have absolute agency over their career. And while they might start as in peer services, and they might say, you know what, this is the career field that I want to specialize in for the rest of my career, they also might say this is a starting point. And we want them to have as much flexibility and opportunity as all individuals have to be able to have growth and development within their careers. One of the things that I think is really exciting that we've been doing is it ties in a lot of some of the stuff that Tony's already been talking about. So for example, if you having those scholarships so that people would be able to have their education paid for is really important. We also have some apprenticeship work that we have done for individuals who might want to become SUDPs or substance use disorder professionals so that they can do that work while they can get their education requirements while they're working, or is another way that we have done things. But I think it is that question of how do we just talk about employment is good for everyone, and there's multiple different career fields. This is slightly outside of the topic of certified peer counselors, but another focus area for our division is also just supported employment in general. So again, how do we talk about how employment is good for everyone, and then support employment as part of your treatment plan?
Interesting. Yeah, good point. We have one other question I'm going to quickly ask. Washington, how did you develop your marketing campaigns? Do you have a contractor help, a private vendor, or do you have some internal communications department that helped?
We contracted it out, yeah, with a
Contract.
private vendor, and I would suggest doing that. Or go look at what we have. It's it's shareable.
Okay, great. Well, I think we have to move on. Thank you so much for these really insightful presentations. You know, for the next, I think we can go to the next slide and go to our next panel. And for our next panel, we're going to focus on the other key issue we're highlighting today as one of the key milestones and goals of the SUD Section 1115 demonstration initiative. And this has to do with initiation and engagement in treatment, another really challenging aspect of, you know, improving access to engagement in substance use disorder treatment. Building on the federal evaluation findings that were presented in the first panel, we did want to also have some of our you know, participants in the SUD 1115 demonstrations talk with you about some of the successful ways they've been able to improve initiation and engagement. As you know, most people that are identified as having a substance use disorder don't seek treatment. So really need to work on going out and improving awareness of the availability of treatment and effectiveness of treatment. So that's what this whole topic area has to do with. let's see, and we're really excited to have representatives from Louisiana, Ford Baker, Nathaniel Dice from Minnesota, and Shanique McGowan from New Jersey with us today to talk about the strategies they've been implementing. Next slide, please. And again, the topics we asked them to cover have to do with what strategies they've used, what outcomes they've seen, and then, kind of what advice they would have for other states. So I think we'll start off with Louisiana, then go to Minnesota, and then New Jersey. So Ford, can we start with you? Ford, I can't hear you if you're talking.
Sorry about that. My phone was on mute.
Okay, great. Thanks.
Thanks, Kirsten. Hello, everyone. Welcome, and my name is Ford Baker. I'm a licensed clinical social worker with the Louisiana Office of Behavioral Health, which is a program office of the larger Louisiana Department of Health. I work mostly in the health plan management section of OBH. I work heavily with our SUD 1115 demonstration and also do many SUD-related special projects for the office. As you can tell from the slide there, we started our 1115 demonstration back in February of 2018 and are currently in our first renewal. And now I'm going to provide a little background and context about Louisiana. Louisiana Medicaid beneficiaries are fortunate. No, go back to the previous slide. There you go. Louisiana Medicaid beneficiaries with substance use disorders are fortunate compared to many states because here in Louisiana, we have a very complete Medicaid covered SUD continuum of care, meaning there are only a few ASAM levels of care that are not Medicaid covered services in Louisiana. And we cover all of the residential treatment and withdrawal management levels of care. SUD 1115 demonstration waivers have also been helpful as a means of funding for states like Louisiana to be able to maintain the excellent work we were doing before the waiver to serve Medicaid enrollees with SUDs and residential and inpatient levels of care known as IMDs. And Louisiana did not add any levels of care with our 1115 demonstration SUD waiver. On the other hand, the SUD 1115 demonstration waivers offered by CMS have been excellent tools for many states that did add treatment and/or withdrawal management levels of care to their SUD service continuums. Those added services have increased access to SUD care for Medicaid beneficiaries across the United States, and more SUD provider capacity nationwide is indeed a wonderful thing. I'm glad to have the opportunity to be here to share an overview about increasing initiation engagement in substance use disorder treatment and hope to inspire some Medicaid managed care states to consider adding the HEDIS measure, initiation and engagement of substance use disorder treatment, or more commonly known as IET, and that's how we're going to talk about it in this part of the panel, to their particular state-specific performance improvement projects with their managed care organizations. And since we had an existing SUD service continuum back in 2018 that was really comprehensive, when we were looking for a possible topic for our 2019 PIP with the MCOs, we landed on the IET measure as it complemented our SUD 1115 demonstration very, very well. So in this section of the panel, we're going to run through some of the why, the what, and the how related to how MCO performance improvement projects, also known as a PIP, can help with supporting Medicaid beneficiaries who may take the risk of starting recovery. And for many on this call, although it may not seem like it, right, it is very, very scary and difficult for those with a substance use disorder to think about giving up their substance or substances of choice. So as a recap of this little introduction, we're going to talk about some of the why, the what, and the how. So let's start with the why. According to SAMHSA, back in 2022, 48.7 million individuals in the United States 12 years of age or older, approximately 17.3% of the population were classified as having a substance use disorder within the past year. Now let's think about that for a minute and put those numbers in a way that's easier to see. 17.3% of the population corresponds to right at 1 in 6 people in the United States who have a diagnosable substance use disorder. 1 in 6 people. So for those 1 in 6 people, let's consider some of the substances of choice that are out there that are being used. We're all aware of opioids, especially fentanyl, and fentanyl analogs, which over the past 4 or 5 years have caused many fatalities because it's being seen in multiple illicit formulations such as counterfeit tablets, mimicking pharmaceuticals, and not just powders. In addition to fentanyl, all on this call also need to be aware there's a new class of emerging synthetic opioids called nitazenes. And some of these nitazenes are actually more potent than fentanyl. Going on to some other substances, alcohol is one of the more common substances used, and alcohol is involved in more substance use related deaths than opioids actually, with over 140,000 deaths a year related to excessive drinking. There are also stimulants, which include cocaine and illicit methamphetamine, in addition to prescription stimulants. And it's also important to realize that stimulants are also fairly commonly seen in polydrug overdoses nationwide. Another class of substances are benzodiazepines, of which that includes what is known as Xanax, Klonopin, or Valium. And last but not least, let's not forget about cannabis. While cannabis definitely has legitimate medical uses, and many states have reduced criminalization of cannabis, we need to remember there are still significant risks for some with cannabis. The high potency of marijuana grown today puts some, especially males, that start use at younger ages at higher risk for developing cannabis-induced psychosis, which is usually temporary, and even developing longer-term psychotic disorders. Most cannabis of 40 or 50 years ago was much less potent than what we see today. So all of these drugs have an impact, and they're even more than that. And I've had the privilege of being part of the healing process professionally to witness the miracle of recovery happen for folks with SUDs and mental health disorders. That miracle of recovery is what attracts many behavioral health providers to the work that we do. And Washington gave a great example of that, that we do helping clients begin the process of recovery. So let's transition to some of the what for increasing initiation and engagement in treatment. What does that beginning of the process look like for a person in terms of the healthcare system or behavioral healthcare system, and how we can measure it as part of a performance improvement project with the managed care organization? Let's go to slide 37, please. Thank you. Okay, here we're going to take a look at a HEDIS measure and incorporating that HEDIS measure into a performance improvement project. And for those not familiar, HEDIS is Healthcare Effectiveness Data and Information Set. And in HEDIS measure language, one measure we use to monitor and track the process of beginning recovery with SUDs is the IET measure. Something to think about with IET is it looks for those that are newly diagnosed, and initiation of treatment is defined as 1 visit within 14 days of diagnosis. Engagement is defined as another 2 visits for dates of service within 34 days of diagnosis. So basically, overall, the IET is looking for 3 visits or dates of service within 34 days of diagnosis. That's the quick and easy way to think of the IET. There are multiple age cohorts to break down by age group, and there are also 3 diagnosis cohorts. The 3 diagnosis cohorts are, one is alcohol, another is opioids, and the last one is other drugs, which includes all the rest of the other drugs except nicotine. So in total, there are numerous individual age, diagnosis, combination cohorts, and total cohorts. So the two rates that I have listed on this slide are the ones that are commonly used to look at the performance of NCOs across states. And it's important to remember that these are total cohorts, inclusive of all age groups and all three diagnostic cohorts for initiation and also for engagement. Now we're going to transition to what a performance improvement project or PIP is with the MCOs and how that can be configured to increase initiation and engagement in SUD treatment. PIPs are a collaboration of MCOs, a quality team from individual states, and the states. Go back to the previous slide. A quality team from the state and the state's EQRO or external quality review organization. The external quality review organization is very important as they are experts on the PIP process. So think of them as the PIP mechanic. They keep it running. And that includes validating the PIP methodology and then also suggesting quality improvement strategies. The MCOs provide quality management and data analytics teams for their respective organizations. And it's also beneficial if the state has a subject matter expert for a particular PIP topic. And I was the SME for this PIP. My role has been to provide clinical technical assistance to our EQRO and the MCOs. And much of that work focused on working with the MCOs to identify barriers and potential interventions to improve rates. Now let's go to that other slide. Thank you. Okay, barriers to initiation and engagement in treatment exist at multiple levels and have multiple possible corresponding interventions as well. So at the MCO level, basically lack of sufficiently trained providers can be a barrier. And back in 2019, the X waiver to prescribe buprenorphine was still in effect. And so some of what our MCOs did at that time was to provide free continuing medical education as a draw for medical providers to become prescribers of buprenorphine for the many who needed it before the X waiver expired. Other examples with the MCOs are process barriers within an individual organization and information flow barriers both within the MCO and between the MCO and providers. So we work with our MCOs to better identify those barriers for changes. With providers, one of the barriers that we noticed was that MOUD prescribers, or back then it was known as MAT, didn't really know commonly who they could refer to go to send the patient for outpatient, IOP, or residential treatment for the psychosocial services that are best to accompany MOUD. So in response to that, the MCOs updated their provider directories and distributed them widely. And also, one of the MCOs actually did some geo-mapping of providers by region, which was interesting. For members, I know they're the commonly recognized social determinant of health barriers that MCOs can help with. But one barrier not often recognized by those that aren't clinicians is what is called the pre-contemplation stage of change. This would basically be someone who doesn't see their substance use disorder or their substance use as a problem. And it really is very common for those with mild SUDs and even into moderate to severe. Basic motivational interviewing techniques are a wonderful, useful intervention for MCO case management staff, their care management staff, and a peer recovery specialist to engage members. And, even beyond that, motivational interviewing is probably one of the more useful tools for all behavioral health and healthcare providers. Now
Thanks
let's
so
go
much,
back
Ford.
to...
Ford, sorry to interrupt. Thanks so much. This is really great information. We do need to turn to our other panelists. We're running short on time. So
Okay.
Next we are going to hear from Nathaniel Dice of Minnesota. Nathaniel?
Yes, thank you. Really pleased to be here. Echo Tisha from Washington State, and just saying that Minnesota is very honored to be asked to come and present on this information. As you can see here, our demonstration was approved in 2019. I'm here to really focus in on the direct access component. I'm going to move pretty quick through the information just so we have some time for New Jersey to present as well. But really what I want to highlight is the array of services that are identified here through a directive that came from Minnesota's legislature in 2016 to really take a look at reforming Minnesota's service delivery system for SUD in general. And so through that directive, Minnesota was instructed to implement a direct access to treatment model where people could go and access treatment directly, and also then have the care coordination. Washington talked about the addition of peer recovery around 2019. Minnesota undertook that as well around the same time, along with incorporating 3.2 and 3.7 levels of withdrawal management based on ASAM's third edition. It also directed the state to explore the 1115 IMD exclusion, which is in Minnesota here, our substance use disorder system reform demonstration, and to really look at a continuum of care model instead of an episodic model. And so between 2016 and 2019, Minnesota did a lot of work to stand these services up and add them to the Medicaid state plan service array. Around that time, also in 2019, began implementation of the SUD 1115 system reform waiver in tandem with the direct access initiative. And there's a link there where you can go to our website and learn a little bit more about that. Essentially, the direct access initiative allows somebody to go directly to a provider of choice, an SUD treatment provider of choice, to get a comprehensive assessment and start treatment immediately. The previous model in Minnesota relied on what we called county placing authorities. And within that model, each county, there's 87 counties in Minnesota, each county had placing authority for individuals that are residents of that county, and had a 30-day window to complete an assessment and make a treatment recommendation, a level of care recommendation for those individuals. And so with direct access, that was, we unwound that particular model, and also allowed us to, with implementation of the 1115 waiver, really align with the evidence-based SUD specific patient placement criteria. So the previous model was missing some of the components that ASAM would look for in a comprehensive assessment, and we were able to really, move that forward and have some consistency across our system. I'll talk a little bit about outcomes and what we saw on the next slide, please. What you can see here is based on the HEDIS measure that Ford was talking about. This comes from our HEDIS measure there, metric 15 of our 1115 waiver. And you can see specifically the opioid abuse. We can look at the initiation and treatment related to this metric, really increasing around that 2020 to 2021 timeframe. We did run a parallel process where counties could still operate in the placing authority model while we had the direct access to treatment initiative standing up through our demonstration process as well. And so we did see a pretty good increase in that initiation trend across those years of implementation and the parallel process. If we can go to the next slide, we'll talk a little bit about engagement in treatment based on that same metric, and this one really looking at ongoing treatment within 34 days of that initial treatment. That continuum of care component that I talked about as part of the reform efforts and part of our demonstration implementation really saw us have some trends related to folks staying engaged in treatment. So moving away from that episodic model and really looking at a longer term engagement in treatment across the continuum. We do know that some of this is impacted. You can see a lot of the really more extreme upward trends there are related to opioid specific engagement and initiation. And you know, obviously there was a lot happening with federal take-home exceptions around that time. And so we see a larger increase there. But you know, if we look at that middle line there, that orange line, and then on the previous slide, there's the yellow line that looks at overall, we do see some trending upwards, which we were pleased to see as we looked at the metrics here. Some of the advice that that I have in terms of you know, consulting with colleagues that were also engaged in a lot of this work, a lot of partnerships with MCOs, with counties, trade organizations, and providers. I think one of the things that we really could benefit from and are looking at and keeping in mind is looking at health information exchange. You know, when we do direct access, folks might get assessed at one program, and that program might not offer the level of care that that individual needs. And so how do we make a referral out and keep that seamless so that there's not an additional burden on that individual upon receiving that recommendation for a level of care? And so that's something that I would recommend as well. And I think Washington talked about that too, just having those base level systems available to support these types of projects is very important and kind of a lesson learned that we have. The other thing too is, you know, Minnesota has a lot of rural area in the state. We have what we call the 7-county metro, which is you know, a pretty condensed area of the state, and then we have a lot of rural providers. And so when we moved to direct access and that shift of what had been a model of treatment in Minnesota for decades, it puts that onus more on the individual to find that access point, whereas in the past those counties really served as that purpose. And so we had to do a lot of training in that, and then also in updating to that evidence-based SUD comprehensive assessment, we also had to have the qualifications of the individual to conduct those assessments. And so at the county level, there was a lot of things that needed to be addressed in terms of workforce there, especially in the rural areas. The other thing that we did in looking at this and some after the fact changes in legislation, we're looking at how do we allow for somebody to get some of the initial services done prior to the comprehensive assessment. So there's the comprehensive assessment for placement and then the comprehensive assessment for treatment planning. And how can we get payment to those providers ahead of that? And so systems work that need to be implemented as part of that as well. And I'm going to pause there and hand it off to New Jersey for their presentation, and happy to take questions after that. Thank you, everyone.
Thank you. Shanique, are you ready to begin?
I'm sorry, I was on mute.
Oh, okay.
Can you hear me now?
Yes. Yes.
Okay, great. Thank you. So hi, everyone. My name is Shanique McGowan. I am a behavioral health program manager with New Jersey Medicaid. Our SUD demonstration was approved in October of 2017 as a part of the New Jersey Family Care Comprehensive Demonstration. Along with SUD, our demonstration includes the state's MLTSS, HRSN, and various other program components. Overall, we use a managed care delivery system, and we have a non-risk-bearing interim managing entity for reviewing placement in all SUD treatment settings for most Medicaid members. So the small subset of members that are excluded from this review include those enrolled in our DDD, FIDE SNP, and MLTSS programs, because behavioral health services for these enrollees are fully covered by their MCO. In addition to covering SUD services provided in an IMD, New Jersey was also granted waiver authority to develop peer recovery support specialists and SUD care management programs. This authority also allows us to transition to a managed care delivery system that integrates physical and behavioral health care. We started doing this with the populations I mentioned in 2018, and we are in the planning stages to continue integrating behavioral health services for the full Medicaid population now. And Next slide, please. So to increase initiation and engagement, our Medicaid office worked with the state's Division of Mental Health and Addiction Services to develop the Interim Managing Entity, or the IME, which also serves as the state's 24-hour call center. This call center is commonly known as REACH NJ. The state identified University Behavioral Health Care within Rutgers University to develop and implement the Addictions Access Center, which includes the IME and the call center, to manage adult SUD treatment services while New Jersey moves toward the integrated managed system of care. So since this initial step was a part of the overall comprehensive demonstration, the IME was able to go live in 2015 and continues to serve as a coordinated point of entry for all residents seeking treatment or information about substance use disorders. During calls, the IME obtains information and reviews individual eligibility for services for financial and program criteria through a statewide database. The program's care coordination staff help individuals to navigate the substance use treatment network and offer assistance when individuals encounter barriers to treatment, such as wait times for admissions or lack of transportation. The program uses ASAM criteria to provide utilization management. Within the authorization process, the utilization management staff ensure that individuals receive the right level of care at the right intensity for the right duration of time. Each time a warm handoff referral is made for SUD services by the Access Call Center, they check EMEV for updated Medicaid eligibility. If the individual is Medicaid eligible, then the IME refers the individual to an appropriate network provider for Medicaid-funded services. If the Medicaid enrollee has a special enrollment status indicating that the behavioral health services are covered by an MCO, then the IME refers them to the appropriate Medicaid MCO. When applicable, callers are referred to their private insurance networks or other state agencies as needed. Next slide, please. So this last slide shares some recent data from July 2022 through June 2023. The IME and REACH New Jersey received about 27,000 calls from individuals seeking information, referrals, or admissions to SUD treatment during this time. During the last quarter of this measurement period, the IME began tracking referrals for MAT at office-based addiction treatment providers, or OBAT providers, and there are about 430 referrals made. And the IME utilization management staff perform about 32,000 clinical reviews for Medicaid members for treatments and admissions. This is during the full year, and about 19,000 reviews for members to extend treatment services. So to speak quickly about adjustments we've made over time, the IME slowly expanded during the initial stages of implementation. As the volume of requests started to increase, delays and determinations began to occur. The state implemented different strategies to streamline the process and required the IME to address staffing needs to ensure determinations were made within 24 hours. Most determinations are now made well within this time frame. As I mentioned, we use a statewide database to monitor information for all contracted SUD providers, including bed management. These providers are required to keep this information up to date. During the beginning of the program, providers who did not submit information about members' discharges on a regular basis led to challenges when the IME would try to admit new members. So to help with this, the IME staff began running reports during the public health emergency, because they had some extra time, to create a length of stay outlier list and reached out to those providers to work through any issues they were having. We also now have a bed management system that is no longer based on provider input, but rather admissions and discharges that are automatically created with certain triggers. So this is public facing and has significantly improved treatment wait times. And lastly, I would advise a state that is embarking on similar work to prioritize training. Training is critical. Each member of the IME clinical review team was trained by the organization that developed the level of care indicator system and the American Society of Addiction Medicine. Interreliability trainings were conducted to ensure consistency across medical necessity determinations. Lastly, I wanted to mention we have found our annual provider surveys to be very helpful to share insight and monitor the effects of our streamlining and the system changes that have occurred throughout the years. And I think I'm turning it back over to Kirsten.
Thank you, Shanique. So much great information. I have so many questions, but we are out of time. Thank you so much to our panelists for bringing so many really insightful strategies and developments that they've been working on. I found this really educational and inspiring. So I hope you did as well. But we do welcome your feedback on this webinar, and there will be a survey link that will pop up after you exit the event. It's also available in the chat, but I think we're about to shut down. So hope you will fill that out and have a great rest of your day. Thank you. Bye-bye.